Welcome everyone to our April Ask the Mito Doc webcast. Today, we will be talking about MELAS. Can you go back the slide? Today, we're going to be talking about MELAS. I'm going to say the full name because I need practice too. Mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. Thankfully, we have the shorter version MELAS to say, and we're going to learn all about it today. I'm excited that we're going to have two great speakers for us tonight. Dr. Mito from Columbia University in New York City, and Dr. Fernando Scalia from Baylor College of Medicine in Houston. Dr. Hirano is going to kick us off with his first presentation, and then Dr. Scalia will join us a little bit later. So I am going to go through a few different things with you. I want to thank Edith L. Trees Charitable Trust and UCB for supporting us always so that we can have these great platforms for webinars. As a reminder, the information provided in this webcast is for general information only and should not be relied upon as a substitute for professional consultation with a qualified healthcare provider familiar with your individual medical needs. Please consult with your primary physician and your other doctors to make sure you know what you're supposed to do. Just so you know, ask your doctor about our no-cost genetic testing program. You can scan the QR code that you see on your screen, and our latest iteration of our no-cost genetic testing program should be starting really, really soon. So please check back, and I'm sure you'll also get some notification from us when it's ready to go. So for our MELAS patients on the line, we want to learn about you and want to find, we have a platform to share your story. If you're interested in sharing your story, please reach out to us, and you can look at our past MELAS stories at umdf.org/MELAS. But to participate and share your own story, you can reach out to Andy Dirth, our communications director, at andy.dirth@umdf.org. One of our industry partners, Ticento, is working on a sort of survey interview process with young people impacted by MELAS. So these are for our 12 to 17-year-olds that have been diagnosed with MELAS. If you're interested, please visit umdf.org/research. And right at the top, there's a button that you'll be able to click that gives you non-drug related studies that you can be a part of, and it's included in there. Oh, something new that we're starting in May is Mindfulness with Mary. Our amazing UMDF support ambassador, Mary Canton, will be hosting a 4-week self-exploration on mindful meditation. So please join us May 7th, 14th, 21st, 28th at 12 noon Eastern time to take care of yourself. We're happy to be able to provide such a supportive kind of activity for our patient community. And you can sign up and register by scanning the QR code on your screen. MitoMed 2024, this is the big one. Our conference is coming up. I think we just talked about it. It's like less than 60 days, which makes me scared and excited at the same time. June 26th through the 29th in Cleveland, Ohio. This is the Super Bowl for the UMDF, where scientists, researchers, physicians, and families come together to learn about the latest and greatest in mitochondrial medicine. So please join us. You can register by scanning the QR code or going to www.umdfconference.org, and you can register there. So let's get started. Our Ask the Mito Doc on MELAS 101. I'd like to welcome Dr. Mito on screen, and I will go off screen and we'll let you take the helm here.
Okay, great. So let me try to share my screen here. Okay, I think it should be showing there. I'm going to put it into slide mode. Okay. All right, so we already had a slide like this. This is the talk on MELAS, mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. And I'm going to cover the first part on the basics and diagnosis of MELAS. And then Dr. Scalia will talk about current and potential therapies for MELAS, and he's actively working on one at Baylor. Okay, so move along here. This is a bit of a historical tour of MELAS, starting with the very first description of this disease. And at that point, it was mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. And it was described by some of my mentors at Columbia, Steve Pavlakis, Dr. DeMauro, Salvatore DeMauro, Daryl DeVivo, and Bud Rowland. And they described two patients that they had seen at Columbia, and there saw that there were 9 others that had similar clinical features with ragged red fibers. That's a finding on muscle biopsy, which we often see in mitochondrial myopathy. So this was a hint of the mitochondrial part, and a muscle, so mitochondrial myopathy. And these young people had normal early development, but were short in height, had seizures, and had either weak hemiparesis weakness on one side, loss of vision on one side, or complete loss of vision due to stroke-like events. And lactic acidemia, or elevated lactic acid, was a common finding. So that's where this name came from, MELAS, originally. Now, I just wanted to note that that when they wrote this paper, Dr. Pavlakis and Dr. Rowland argued about these events in the brain that presented like a stroke with sudden neurological deficits with loss of vision or weakness on one side. And so Dr. Rowland said they were strokes. But Dr. Pavlakis argued, no, they're not really strokes because they don't look like a normal stroke on imaging. This is an old CT scan showing the lesions here in the back of the brain here, and this is the front of the brain. And they didn't look like a typical stroke where you have a occlusion of a blood vessel and you have a wedge-shaped lesion. They were more along the surface of the brain. So they were atypical strokes, and they also affected young people. So they compromised by calling them stroke-like episodes. So I got involved a few years later. An original paper was published in 1984, and I got involved a few years later when Dr. Rowland pointed out that one of the original cases was reported only in abstract form, and that was a case of Dr. Koenigsberger. So I reviewed that original case and the literature and found that there were about 69 other cases at that point. So the number of patients is expanding pretty rapidly after that first paper. And this is the story of that original family. And you'll see here that there's the women or girls are depicted by circles, and the males are shown in squares here. So this is the mother and father who are in white, meaning they're unaffected. But this unfortunate girl had a severe illness, and the line means that she passed away at age 10. And this shaded box means that this young man was affected, but less severely than the sister. And these other 2 sisters were unaffected. So this first young child was normal in the first 2 years of life. So she had normal early development. And then she was noted to be weak. She had difficulty climbing upstairs. Oops. And at age 5, she was noticed to be short and thin. She was less than the 3rd percentile for both height and weight. And a few months later, about 6 months later, she started having these neurological episodes of dimmed vision or impaired vision. And subsequently, 6 months later, she had overt seizures. So these, in retrospect, were probably early stroke-like events that weren't recognized as such. She subsequently developed hearing loss, and because of her brain lesions, she became demented and lost her cognitive abilities. And at age 10, she developed heart failure and passed away. And she had an autopsy that revealed multiple strokes on the surface of the brain. So again, these atypical strokes. Her brother, who was 17, had a history of mental retardation, hearing loss, and short stature. So you think, wow, what an unlucky family that they have these 2 children with different diseases. because they seem so different in many ways. But in fact, they had the same genetic problem. So we analyzed we reported that original family and analyzed the 60 some odd cases that had been reported in the literature to that point, and we came up with a revised definition of MELAS. And we, instead of calling it mitochondrial myopathy, we condensed it to mitochondrial encephalomyopathy, brain and muscle involvement, again with the lactic acidosis and stroke-like episodes. And we defined the syndrome, or we refined the definition as having stroke-like episodes typically before age 40, and then the brain involvement characterized by seizures and dementia or both due to the accumulation of these stroke-like episodes. And then lactic acidosis and ragged red fibers indicating the mitochondrial component. So this was a clinical definition, and a major breakthrough occurred in 1990 with the identification of the first point mutation linked to this disease. This was reported by Drs. Goto, Nanaka, and Horai in Japan, and they identified this particular. This is a DNA sequence going across the screen here: humans, cows, mouse, and rats, and so on. And you'll see that at this position here, it's number 3243 in the mitochondrial DNA. There's an A in all of these organisms. So it is conserved over evolution, which means that it's probably very important. And in fact, when it was changed from an A to a G, it affected this particular structure called a transfer RNA. And you can see here that A is mutated in about 80% of the patients with MELAS. And it holds true today. This is the most common genetic cause of MELAS, this 3243A to G mutation. So when we went back to that original family, we found that they all shared that same mutation, the 3243 mutation, but because mitochondrial DNA is present in multiple copies in each cell, there are hundreds of thousands of copies, you can have a variable amount of the mutation. And in this case, the young girl who passed away was not tested because she passed away before the mutation was identified. Sorry. But her brother had about 14% in blood, and her sisters had 15 and 55%, and the mother had 59%. That's a little odd because this young man, who was 17, was affected with cognitive issues and seizures. So this is in blood, and that doesn't necessarily reflect what's going on in the brain. So presumably he had a higher level in brain, and the sister, who was severely affected, had an even higher level in brain and heart, and causing her multisystemic disease. So since that original report in 1990, more than 25 other mutations of mitochondrial DNA have been linked to the MELAS phenotype. But as I said before, this tRNA leucine, the 3243 mutation, accounts for about 80% of the patients with MELAS. And these other mutations are less common. There are even reports of nuclear gene defects in the polymerase gamma gene that can cause a MELAS-like phenotype. So there are many different mutations that can converge on the MELAS phenotype with the stroke-like episodes. So multiple genotypes with one phenotype, the MELAS phenotype. So with this identification of mutation, we have to revise the definition of MELAS again. So again, we retain the mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. But now I think we would all generally agree that they're characterized clinically by these stroke-like episodes. Here you can see in an MRI, so the imaging techniques have improved. It here more clearly shows that it affects the surface of the brain, the cortex. And it's not only a brain disease, but muscle disease, because we have ragged red fibers and elevated lactate from the muscle. And to be absolutely certain of the diagnosis, we have to identify a pathogenic variant or mutation in the mitochondrial DNA, in most cases, rarely in the nuclear DNA. So that's how we define MELAS. This mutation, the 3243, that causes 80% of cases of MELAS, is the most frequent pathogenic variant in the North American Mitochondrial Disease Consortium registry. So it's a frequent mutation, and as many as 1 in 200 people may carry this mutation. That doesn't mean 1 in 200 people is going to develop MELAS. Most will not, of course, because they have lower levels of the mutation. Nevertheless, it is a fairly frequent mutation in our database as well as others around the world. But what we see here is that although the 3243 mutation was originally linked to the MELAS with the stroke-like episodes, it's actually not one of the most common manifestations of this mutation. So in fact, hearing loss, exercise intolerance, and diabetes are more frequent clinical manifestations in around the world. And we see that there are many patients around the world identified. This number has grown much larger since these reports. At Columbia, we've been doing a natural history study of patients with this 3243 mutation. It was run by Daryl DeVivo, who was a pediatric neurologist, an extraordinary clinician and investigator who was part of that original report. And he carried on this natural history study for more than 20 years with Chris Engelstadt, his study coordinator and genetic counselor. And over the years, 179 subjects with this mutation have been followed, including 63 who had the full MELAS phenotype. And then there were quite a few, actually, the majority had the non-MELAS phenotypes. They were carriers of the mutation, but they didn't have the stroke-like episodes. And this is some of the things that were done over the course of this 25-year study. The questionnaires, there's careful clinical examinations of patients, neuropsychological assessments, and 6-minute walk tests were performed on these, and laboratory studies as well, routine blood tests as well as brain MRI studies and special blood and urine biomarkers over the time. So just wanted to point out that as I said before, the MELAS is defined by the stroke-like episodes. So 100% of the patients had MELAS, but you'll see that they have many other problems beyond the stroke-like episodes, which seizures are very common with the strokes, hearing loss, exercise intolerance. And you'll see that the other people who didn't have the stroke-like episodes or not typical MELAS stroke-like episodes, they also had shared many of these problems, but the proportion of these problems was almost uniformly lower in the non-MELAS mutation carriers compared to MELAS. So MELAS is clearly the more severe end of the spectrum with the stroke-like episodes, but these other problems in the various parts of the body. So it's really a complex multisystemic disease in many individuals. And unfortunately, as the first child illustrated, it's a disease that progresses, and about this median survival, that is 50% of the people with this condition survive about 17 years from the onset. That doesn't mean that all will die in 17 years. Many survive much longer, but it can be a very progressive, and unfortunately, in many cases, the strokes are relentless and can recur. So we desperately need therapies, which Dr. Scalia will talk about. And this is just a study that we're doing led by Dr. Valentina Emanuele to see if there are markers that can be identified in the patients who are mutation carriers but don't have MELAS. Are there markers that might predict the stroke-like episodes? And if so, then that might be those are the patients we would target for the therapies. And so this is what she's doing. She's looking at the clinical and metabolic features of these patients who are carriers, and seeing who have converted to the MELAS, and identify what the risk factors might be, whether they are clinical factors that can be identified, or imaging, or blood biomarkers. So she's hoping to tease that out. And so, oops, sorry. So the data are being collected, have been collected in this natural history study, and she's in the process of analyzing the data. And if there are other people who are interested in participating, or at least their clinicians, perhaps, we can contact, you can contact us, and we can collect your data to validate whatever Dr. Emmanuel finds in the original cohort. I'm sorry. And with this, I'll end, and I'll end by sharing. And I think Dr. Scalia will take over now.
Thank you so much, Dr. Irano. So, we'll get started with with therapies, and first, yes, so essentially I'm going to cover current and potential therapies for MELAS, and as Dr. Irano mentioned, a big cause of morbidity or problems in this mitochondrial syndrome is the presence of metabolic strokes. And it has been thought that this mitochondrial proliferation that actually occurs in cells surrounding small blood vessels of the brain may result in dysfunction of these small blood vessels and decrease availability of nitric oxide. And nitric oxide is known to regulate the tone of the smooth muscle surrounding these blood vessels. And as we can see here, the strokes, in particular on the right, in the figure on the right, I mean, we do see that they involve the posterior part of the brain. I mean, the occipital areas, although other areas can be affected. So in the next slide, if we go to the next slide, so we do see that yes, typically the posterior part of the brain will be affected, and one thought is that there is an accumulation of the abnormal mitochondria in the lining of the smooth blood vessels, and also in the muscle, the smooth muscle layer that surrounds the blood vessels, and this could be responsible for the strokes, because it may affect the availability of nitric oxide. So we typically see, as we can see in this red arrow that actually points to the affected area of the brain, that these are not areas that are typically supplied by large blood vessels. They don't follow the territory of large blood vessels, and it may involve problems in small blood vessels. And then here we can see that there could be effects of L-arginine in restoring nitric oxide production. So in the next slide, we will see that, that arginine supplementation has been observed initially in Japan, that actually led to clinical improvement in patients with MELAS. And in addition, in Dr. Irano's group in Columbia University in New York, it was also observed that plasma citrulline levels, citrulline is an amino acid, was reported to be low in patients with MELAS. And as we can see in this diagram, so arginine and citrulline are also precursors of nitric oxide. Alternatively, it has also been postulated that if seizures are not very well controlled in MELAS, that this hyperexcitability of brain cells, of neurons, can actually lead to the accumulation of toxic metabolites, and these toxic metabolites can actually cause a decrease in the integrity of the blood-brain barrier and lead to brain swelling. And with that brain swelling, we will have the appearance that there are like stroke-like episodes. So it could also be, there could also be a factor with the lack of adequate control of seizure control. So in the next slide, we have, yes, so this slides actually shows that when we look at control patients and patients with MELAS, and this would be folks who actually are healthy that don't have this mitochondrial syndrome, when we compare the arginine concentration, the citrulline concentration tends to be lower in MELAS, and more so in the acute phase of the metabolic stroke. So plasma arginine levels are low. So in the next slide, so what I'm presenting now is actually what was initially researched in Japan by Dr. Koga, who's a neurologist, and actually patients with MELAS, when they receive intravenous L-arginine that was compared to placebo, and this was given within 3 hours of the onset of stroke-like episodes, that they experience improvement in their symptoms that included weakness and headaches. And in the next slide, we do see here that, so if each horizontal line represents a patient, and if we see here like a dotted line in the middle, this is actually the time where oral arginine was given. Arginine is again an amino acid and a precursor of nitric oxide like citrulline. And we do see that these vertical lines represent the number of strokes. And so they had this observation, or presented this observation, that after starting oral arginine, the number of strokes decreased. So, however, at that time, this was not part of a study, like a randomized, double-blind, placebo-controlled study or clinical trial. So the observation was there was a decrease in the frequency and severity of the symptoms caused by stroke. In the next slide, so if we talked about like current treatments, at least we should say that in Japan and also in North America, the United States, and Canada, there is a consensus that at least if a patient with MELAS presents within like 3 hours within the onset of symptoms, that intravenous arginine could be used. It could be given as a loading dose, and then it can be continued for like 3 to 5 days. So some of us clinicians and investigators under the umbrella of the Mitochondrial Medicine Society, we publish recommendations for the management of stroke-like episodes in patients with MELAS by using intravenous arginine. Now I'm going to talk, switching gears, but continuing with the same theme of nitric oxide. In the next slide, we can see that we conducted studies at Baylor College of Medicine, and initially it was done at Texas Children's Hospital. We were wondering whether citrulline, which also generates nitric oxide, could be a more effective precursor. Why? Because, as patients take arginine by mouth, there is an enzyme that breaks down arginine in the intestine, that then arginine is metabolized in the liver, but citrulline is not. And then because of oxidative stress, that actually may make arginine, it may actually hamper the entry of arginine inside the cells. So for many reasons, we thought we should compare, we should look at citrulline versus arginine. So in the next slide, we actually have this hypothesis that actually subjects or patients with MELAS syndrome have problems with nitric oxide that both arginine and citrulline, we compare those two, would increase nitric oxide production, but that citrulline, for the reasons that were already mentioned, would lead to an increased nitric oxide production at a higher degree than arginine supplementation. Citrulline would be more efficient. So in the next slide, we did see that actually when we compared, these two arms, so the two bars on the left with the two arms on the right, we did see that the synthesis of arginine increased markedly with citrulline supplementation when we compare that with arginine, and actually also the production of nitric oxide increased to a much higher level when compared with arginine supplementation. So this was part of a pilot study, not a clinical trial, and then that led to the start of a clinical trial, which we have in the next slide. We'll talk about that. So this actually, the data, the results from these studies actually were published. So we showed, this is what we just presented. So this was published in adults. And then in the next slide, we have the other publication in children. So in children and adults, we found similar results when comparing arginine and citrulline. And now in the next slide, I will be presenting data so this was actually our mechanism that there would be decreased citrulline synthesis. The decreased citrulline synthesis or production of citrulline in patients with MELAS would lead to decreased production of arginine, decreased production of nitric oxide, and that this will lead to the impaired perfusion in the small blood vessels, and that would lead to the metabolic strokes. So in the next slide, yes, we have a trial. We finished recruiting patients. We actually recruited 10 consecutive patients. These were the inclusion criteria. They had to have the clinical diagnosis of MELAS with like neurological and/or muscle symptoms with stroke-like events, seizures accompanied by exercise intolerance, fatigue, the age of 18 through 65 years, and the same genetic letter change that was presented by Dr. Irano previously in this gene, MTTL1. And of course, they could not be, or at least prior to a week, prior to the initiation of the study, on arginine or citrulline or any other medications affecting nitric oxide. So in the next slide, yeah, we actually had to get permission from the FDA, and we had an IND, and to look at maximum tolerated dose of L-citrulline in 10 consecutive patients. We started with like 10 grams per day, and then obviously we proceeded, and that amount of citrulline was divided 4 times a day. And we were looking at safety because this was like a phase 1 study, and we were looking for safety outcomes such as like low blood pressure or low blood sugar or headaches, which could be connected with the production of nitric oxide. And then there were like secondary outcomes. We did research brain MRI. We also look at metabolic profiles in these patients. And then on the next slide, we are proceeding now with data analysis. So essentially, we have approval by the Baylor Ethics Committee to conduct the study, and we have also an independent medical monitor, the Data Safety Monitoring Board with weekly meetings, and then 10 participants have been screened, enrolled, and finished with the study. And currently, we are proceeding with data cleaning, and hopefully next week with data log and data analysis, so we can present it and share that with the community and look at the results of citrulline. So now, going to the next slide, we talked about the current treatment with arginine, with IV arginine and oral arginine, the trial that actually we conducted, and the data analysis that is proceeding with the citrulline trial. And now I wanted to talk about this molecule, which is, so this is Sagosiwat. The mechanism of action is really through is the stimulation of guanylate cyclase, and this will lead to the production of cyclic GMP, or cyclic guanosine monophosphate. Initially, this compound was actually evaluated in individuals, participants with dementia, so like problems with learning and memory formation. And so this was initially developed for the treatment of neurodegenerative disease, but we do see that actually this is an stimulator of the production of cyclic guanosine monophosphate, and it operates downstream of nitric oxide. So we think that there is a connection with that and with the nitric oxide pathway. And in the next slide, we'll see that there was an open label study. Dr. Irano's site participated looking. It was an open label study in patients with MELAS. There were several centers that actually participating, and they were also looking at evaluated this compound, which was given like once daily, and genetically defined patients with MELAS were recruited, and it was a safety tolerability study, and it was really looking more at the impact on biomarkers, and they also have like brain imaging data, and there was improvement in lactate and cerebral blood flow. So right now, a trial, which is like a double-blind, randomized, placebo-controlled trial using this compound, which is now no longer called IW6463, is Sagosiwat, is being implemented in different centers, and the potential start date would be the fall for the trial, would be the fall of 2024. And then on the one of the last slides, if we proceed, we can see, so for this particular study, so there was improvement observed across important biomarkers. So this is the study looking at Sagosiwat, so they looked, as mentioned in the previous slide, at cerebral blood flow, and also there was also an evaluation of biomarkers associated with mitochondrial function. I have mentioned lactate, but also GDF15 was evaluated. And then, as I mentioned, there's a planned phase 2b clinical trial with this compound. And in the next slide, I also talk about something that potentially could happen that is not ready yet, but it has been evaluated in preclinical models, and it's a gene editing tool called Mito that has been fine-tuned to, in this case, the idea would be to shift the heteroplasmy downward, the percentage of the mutation load of this particular mutation, without harming what we would call the normal mitochondrial DNA, or even the nuclear DNA. So this could potentially pave the road to the first human trials. And I thought that, okay, that's something that hopefully will happen in the future, but we are not there yet. So thank you for your attention. We can actually go to the next slide, and I think we are open for questions.
On and come in, trying to get my camera to turn on. Well, thank you both for such an interesting presentation, and in all honesty, so many of the things that you covered are questions that I get every day. I do have, I'm going to pop into the Q&A and see what's there, and sort of, I see that Dr. Hirano is actually answering one question. One of the other questions in the Q&A is that the two studies mentioned are for children and young adults over 12. Are there any studies in MELAS for children younger than 12?
Do we answer them live, or?
Oh yeah,
do we...
yeah. This is your time to talk.
Okay.
Yeah, sorry.
Well, no. So obviously, so that's actually a very good question. So the the trial that was done as part of NAMDEC, the mitochondrial registry at Baylor, that was for adults 18 and 65. This new trial with this compound, sagosiguat, will not be done in the pediatric population, at least not initially. Would also target the adult population. So I'm not aware of any pediatric trial at the moment. Yeah.
And
Existing.
could you talk a little bit about why we often do see studies in adults first? Is there a reason for that?
Well, sure. I think that, I can talk about the experience with planning our clinical trial using citrulline. The FDA wanted to first trial in adults, for issues that, the pediatric population is a vulnerable population. So, they would, for many conditions, they would prefer that the adult population would be studied first.
Right. Yeah. Thank you. I'm going to go to jump off of the Q&A on our screen and go to a question that I have received lately. Should a person with MELAS secure genetic testing for other family members? And if so, what kind of testing should they do? Siblings, children, that kind of thing. What are your thoughts there?
So I can answer the question, sure, but I also, anyway, Dr. Irano obviously can chime in. Well, I think yes. If there is a family history that obviously one family member is affected with MELAS, then I think it's pertinent to test other family members, because they could have other issues. When we obtain a family history, there could be, and I think we have to be also careful. I think that we tend to call MELAS to everything that is connected with this particular genetic letter change, the 3243. I think that now there is a movement to call this 3243 related disorder. There may be family members, maybe one family member who was ascertained first had MELAS with strokes, with metabolic strokes or stroke-like episodes. But other family members may have hearing loss and diabetes, or they may have hearing loss and short stature. So it may be pertinent to test them, because there are, if we know, it's not putting a label, but if you diagnose somebody with a genetic condition, then that person can be screened and go through a surveillance protocol.
Thank you. Another question that I wanted to get to, that again is a question that I've received this week from a person I talked to, is that can people develop MELAS symptoms later in life? And why does this happen if the genetic problem was always there? Both of you. Oh, Dr. Irano, I think you're muted.
I think Dr. Irano is muted.
You are muted.
Yeah,
There he
so
goes.
yeah. I'll start, and then Dr. Scalia can join in. So yes, we don't know exactly why some people are affected by the stroke-like episodes at an earlier age than others, but there's quite a variation from early childhood up to people in their 60s who have their first MELAS stroke-like event. It may be related to the level of the mutation in the brain. In general, the higher the level of the mutation, the more severe the disease, and those who have very high levels will have this most likely to have the strokes at an early age, and those with a high but not super high level may develop the stroke-like episodes later in life.
There's a related question in their Q&A that I want to get to. My mom, here, I'm going to just read it to you. My mom did not develop stroke-like episodes until about 45 or 50, and she passed away at 69. Her blood percentage was 20 to 25. My son and I both have 25 to 30%. Does this mean we will develop the same issue symptoms later in life?
Yeah, you want to?
There is a lot of variability, and I think that There is a lot of variability because there's well, first, maybe the person who unfortunately passed away may have had much higher levels in muscle and brain, and sometimes there is, when I said there is variability, there is also variability in the sense that if maybe the source of the test was a blood specimen, the percentage of the change of the mutation or the heteroplasmy can decline over time. Muscle may actually give like a more reliable, reliable measure. But I think that, as Dr. Hirano alluded, there is, there are other groups that are looking beyond the heteroplasmy, could maybe some background effect of the mitochondrial DNA, or maybe nuclear genes have some type of modifier effect on this. So yes, we all think that the higher the mutation load, maybe the worse the outcome could be, but there could be other factors too. And I don't think that we know all about that.
Thank you. That is a really important question that I get all the time. Here's another one that it has come up before. Can MIDD turn into MELAS? I guess with the addition of stroke-like episodes. What is that?
So yeah, maybe we should define MIDD, which is the acronym for maternally inherited diabetes and deafness. And yes, the disease can evolve over years, and what may start out as a diabetes and then deafness it may stay that way for decades, or it may evolve into a MELAS picture. And unfortunately, that's the problem that Dr. Manuel is trying to sort out, is is there any way to predict who will convert to the MELAS? And if so, what are the factors that might influence that? And are those factors, can we intervene and prevent the stroke-like episodes? So she's looking into that, and hopefully we'll get some clues in the futures.
And as you referred to Dr. Emanuela's research, has her research been published yet?
No, she's still in the process of analyzing the data.
Okay. And do you know when we should be able to learn a little bit about some of the findings?
I can't predict at this point. Actually, it'll also depend on the participation of people, some of the people in the audience today, because we will need more data and more information from patients and their families. So it might be will certainly be helpful to have more information, and that will speed up the process.
Well, thank you for bringing it up, because I'd also like to take this moment to thank all of the folks impacted by MELAS that are on this call, that have participated in clinical research and have tried to get into these studies, because we need you, and this is how things are going to change. I did have another question. How long will it be before there is a treatment for MELAS? And what about gene therapy? What's getting in the way?
Okay, so how long before there will be a treatment? Well, I mean, I think that so far, I think that, what has been done with, let's say, arginine and even I would predict citrulline, although, hopefully we will be able to share those results at the UMDF meeting, and obviously presenting at other meetings and publish that. It's probably not going to go to the bottom of the problem here. I think that probably what will go to the bottom of the problem will be a genomic approach, and by that is probably what this person is asking about. Gene therapy. There has been work done by Dr. Moraes in Miami, looking at, again, not patients, but preclinical models, and looking at enzymes or proteins that would actually target a particular segment of the mitochondrial DNA where the genetic letter change is, with the idea of that hopefully eliminating that, right? And that's why, the last, there were there was like zinc finger nucleases and mitotalens, and now we have this system called mitoarcos. But so far that is currently, it was evaluated actually in a mouse model, not necessarily with the same not necessarily with the same change that patients have, but in cellular models. So I think it's very important that if a group or a research group is planning to do a genomic approach, or like gene editing, to make sure first safety, right? Safety is very important. So we cannot rush through things, and that's why initially there is experimentation in preclinical models or animal models of the disease. So we are not there. We are not there yet.
Mhm.
You want to make sure that if something will be delivered or inserted, that there's not going to be toxicity to other organs, or what people would call in the field like off-target effects. That's not good.
Mhm.
Do you have
Um,
any comments on that, Dr. Verano?
Yeah, I just want to make two comments about genetic therapies for MELAS, or mitochondrial DNA mutations in general. One is that we cannot put DNA into mitochondria. We can put DNA into cells, but they can't get into the mitochondria. So that's a technical barrier. So we can't do gene therapy for MELAS and the other mitochondrial DNA diseases in the same way that the gene therapy for spinal muscular atrophy or other diseases, genetic diseases, are treated. But there is an Achilles heel in the mitochondrial DNA, because it's a mix of wild type, of normal and mutated mitochondrial DNA. So as Dr. Scalia pointed out, there's therapies to get rid of the mutated mitochondrial DNA through MitoArcus or other technologies can lower the level of the mutation and presumably make a person less symptomatic from that same mutation, because you lower the mutation burden.
Oh, very, very interesting. I have a question that's in the Q&A, but I'm going to paraphrase it a little bit.
Huh?
With MELAS, what are the possible inheritance patterns? Can you quickly and make it as simple as possible on the ways that MELAS can be in families?
Well, so I think the I guess the mutation, or the syndrome caused by this particular mutation described by Dr. Irano, Dr. De Vivo, Dr. Di Mauro, that's what we would call maternal inheritance, right? So that's actually passed through mom to children, boys and girls alike, and then men, typically, would not be able to pass that on. However, and that actually there's a nuance to that, in the sense that the name, there are other conditions, like for example, there are patients who may have changes in another gene called POLG. They may also present with like a MELAS MELAS presentation with metabolic strokes, and in that particular case is very different, because it would be recessive. I have a patient whom I followed. I have a patient whom I follow who has, she was referred to me for evaluation of MELAS, and she had metabolic strokes, but she had 2 changes in POLG. She doesn't have the change that Dr. Irano illustrated first. So it can be different, right? In that case, it's different. It's both parents are carriers, and the child actually has received 2 non-working copies for that particular gene.
And what testing? To go back to the question we asked before, what exact testing should families be doing? I guess if they know what the issue is with patient, one of the patients, then they would look for that in all of the others. Is there anything else they need to think about? And what type of testing would that necessarily be for that family?
If this is a family with MELAS, or just, yeah, so if it's MELAS, it's most likely a mutation in the mitochondrial DNA, and because the the sequencing technology has advanced, it's possible to sequence the entire mitochondrial DNA and pick up not only the most common MELAS mutation, but any other known pathogenic mutation in mitochondrial DNA in a single test. So the technology has improved dramatically and made it easier to make the diagnosis.
Thank you. Also, I want to move on to this question, and it may not be one that you can answer, but you may. What would the typical doses for arginine and citrulline be? Is that something that varies from patient to patient, or is that something that's fairly consistent?
Well, for citrulline, I prefer to have like the final data analysis before I present that, rather than creating a expectations. So I think this is, and it's not that I'm trying to withhold information. I think it's good to analyze the data, and then once we present it, it will be presented to colleagues and to the public, right? People will know. I mean, so I mean the doses that I think that the question was pertaining to citrulline, right? The doses for arginine, well, that I think has been published. Initially was published in Japan by Dr. Koga's group. They were using 500 milligrams per kilogram, per dose, or per, I would say like per day, and that was being divided if it was oral, if it was given through an IV, through an infusion, then it was also 500 milligrams per kilo. There was some variability there. In the paper published by some members of the Mitochondrial Medicine Society in JAMA Neurology, the dose that was used was 500 milligrams per kilogram per dose. It was that actually paper focused more on the IV dosing of arginine. Yeah.
All right, now I'm going to do a quick fire questions to see how many we can get done. Is it common to have heat and cold intolerance with MELAS?
Dysautonomia is a frequent feature of MELAS, and there was a report by Petra Kaufman about that.
Oh, perfect. How did the cheek swabs and urine tests for 3243 compare?
Good question. I have, so I think it was cheek swab and urine. Was that the question? Yeah. So, we used to do, we used to rely on urine because certainly blood sometimes was not reliable in the sense that you would get declining over time, declining percentage of heteroplasmy. Urine was more reliable. There was a time when we had, well, let's say closer to in-house testing. I don't want to get into an interesting area, but now there is one. Well, I think that actually there may be two labs in the US, a commercial lab and an academic lab that actually may be offering, urine test. I think I have relied on that. With cheek swabs in general, it can be reliable, but I've seen discrepancies. Maybe that has been like my personal experience. I've seen discrepancies between cheek swab and blood and cheek swab and other tissues. So, we use it for nuclear gene testing. For mitochondrial DNA, it would be interesting to hear what Dr. Irano has to say.
Yeah, I think that in general, the levels of mitochondrial DNA mutations are higher in urine and cheek swab than in blood. But it's not, I don't think there's a consistency between urine and cheek swabs. I think sometimes one is higher than the other, and in other cases the opposite is true. So I think we often use cheek swabs now just because it's more convenient, and there are kits that some of the commercial companies send to the patient's home, and they could just swab themselves. And so I think that's why I think the field has moved towards cheek swabs as a screening test, but it's not perfect.
Well, thank you for that. I'm going to kind of move towards wrapping up. If we didn't get to your questions, we will make every attempt to get them answered post-event. I have one last question for the doctors as we say our goodbyes, and we'll have a slide at the very end. But and this will be for both of you. What part of the MitoMed conference do you look forward to the most? And I'll start with Dr. Hirano. What's your favorite part?
Oh, my favorite part? Well, That's a tough one to answer, but I always love the interactions with the patients in the sessions, the Ask the Mito Doc sessions. That's always exciting. And then on the other end, I like the cutting edge science that's presented at earlier in the conference. So it's really this is a unique conference in having both represented. So I always have both. Yeah.
Is there anything about this year's agenda, if you've had a chance to look at it, that you're particularly excited about?
I haven't looked at the agenda carefully enough to say that yet.
I was gonna guess that you had it, but I think Dr. Scalia has, because he's been
Yes.
very involved in creating it. So I'm gonna move on to Dr. Scalia next, and same question for you. What part of the MitoMed conference do you look forward to the most every year?
Well, I mean, I think that, like Dr. Irano said, I think that I very much like the interaction with the families and the fact that, they ask the Mito Doc session, or the doctor, the doctor is in, and all these different like breakout sessions. I think that that actually makes this conference very unique. It's not just for, doctors or scientific attendees, but for families. I think it's very good to have, this interaction is what makes us stronger. I mean, I think the cutting edge science, and I can actually think about, some of the topics this year. And, there's also going to be like a lot of emphasis on more basic science, like model organisms for mitochondrial disease. That's actually exciting because, we may be able to study in animals or other organisms what may happen. And, and that's sort of like the testing ground for like novel therapies, right? And then there's also going to be like an emphasis on clinical trials and outcome measures, and maybe like, patient-focused outcome measures for clinical trials. That's actually very important, like validating scales. That's terribly important for clinical trials, right? Or validating, so sometimes we like to measure things, but if they are not validated, that actually would make it like less relevant. And I think that that's terribly important for a clinical trial.
Oh, well, thank you so much for that. And I want to thank you both for this evening. It's been incredibly informative. Having a enduring material of this event at my fingertips is going to be really helpful to our patients that are newly diagnosed. So thank you so much. I did want to talk about next month's Ask the Mito Doc webcast, which will be on Wednesday, May 29th, from 7 p.m. to 8 p.m. Eastern Time. And the topic will be Ask the Mito Doc webcast series, Mitochondrial Disease Basics. And we will have Melissa Walker from Mass General Hospital. So mark your calendars for May 29th. As we wrap up, I want to thank Dr. Hirano and Dr. Scalia, but I also want to thank all of our amazing patient families that kept us busy in the Q&A tonight. So thank you all, and we'll see you next month for Ask the Mito.